about the chapter on upper limb orthotic and prosthetic. Dadah! Radial control system. For a transradial or below elbow prosthetic, use single control system. This system is simple because it uses just one cable to move the terminal device like a hand or hook. There are two types of terminal device. One is voluntary opening, where the patient opens the finger by pulling on the cable and the rubber bands closing. The other is voluntary closing, where the patient uses their strength to control how hard the device grips.
Salah, why we need harness for ULP?
Harness for ULP to help operate the terminal device for using body motion and keep prosthetics secure and stable on the stand.
Thank you.
Component of standard figure 8 harness transradial include one axillary loop. This is the main part that attached to the shoulder on the working side, and two anterior support straps. This strap help prevent the prosthetic from falling down. 3. Control attachment strap. This strap is connected to the control cable and tightens when the user moves. 4. Cross point. This part is placed just below chain 7 area to work most efficiently.
Salah, how prosthesis powered by body motion?
Shoulder flexion and scapular abduction open the terminal device. When the shoulder relaxes, the terminal device closes again with the help of rubber bands.
Thank you.
You're welcome. Transhumeral control system. For a transhumeral, there are two control cables. One is primary cable, used to flex the elbow and operate the terminal device. Two is secondary cable, used to lock and unlock the prosthetic elbow. To operate a transhumeral prosthetic, the user needs more cable excursion. Harness for transhumeral prosthetic. The figure 8 harness can be modified for above elbow user with additional strap, lateral support strap for suspension, and elbow lock control strap to control the secondary cable. Sometimes a crossback strap is added for comfort and easier operation. 7. Wrist alignment. Wrist alignment helps the user bring the device toward the mouth. Generally, about 5-degree flexion and 5-degree radial deviation give optimal function. In Monster design, the forearm is pre-flexed at around 13 degrees. What is elbow disarticulation? Elbow disarticulation is a type of amputation that takes place at the elbow joint. This means the upper arm bones called the humerus remain fully attached to, and only the lower part, which includes the forearm, is removed. Since the bony bones on the humerus, known as the epicondyle, are kept intact, this type of amputation creates a clear and distinct shape. It also offers special advantages when it comes to attaching and moving prosthetic limbs. Okay, now I'm talking about the anatomy. Usually, the elbow joint connects the trochlea and capitulum of the humerus to the ulna and radius. When the elbow is spreaded, several soft tissues are impacted. The origin of the pronator tears is taken away. The brachial artery is spreaded and tied off, and the nerves are pulled down and cut. The tendon of the bicep and brachialis lost their usual attachment point. The extensor muscles are cut and used as a cushion for the soft tissue. That's why taking care of the soft tissue is very important. Early management upper limb prosthetic. After surgery, early care focused on 1. Reducing swelling, managing pain from the amputation, improving blood flow, and helping the area heal quickly. It's best to start fitting a prosthetic limb early because the longer someone uses their other hand, the more difficult it becomes to get used to a prosthetic later on. Residual limb consideration. When evaluating an elbow disarticulation stem, we consider 1. The length of the limb, 2. The condition of soft tissue, 3. The shape of the limb. Muscle strength and range of motion. The shape of the distal limb greatly affects suspension. If there is too much soft tissue, the humerus condyle becomes less prominent, making suspension and rotational control more difficult. But when the contour is clean and not too bulky, the epicondyle provides a natural anchor, improving suspension and rotation. Suspension and socket design. Rotational control for elbow disarticulation can be achieved in 2 ways. 1 is flattening the anterior and posterior socket walls, and 2 using proximal wings with suspension strap. There are also socket alternatives, such as spline socket with external elbow joint placed on the side and elbow locking unit which can be inside or outside the socket. For cosmetic or lightweight use, suspension above the condyle may be enough, but for heavier functional tasks, additional suspension such as strap or shoulder supports may be needed. Advantages of elbow disarticulation. 1 is allow bone growth in children. 2. Faster and cleaner surgical procedure. 3. Excellent suspension due to the condyles. 4. Good retention control, more functional than transhumeral amputation in bilateral cases. Disadvantages with disarticulation is poor cosmetic appearance because the elbow center appears lower, limited space for elbow joint component, and 3. Less durability of component due to tighter space. Now we're talking about the prosthetic component. Prosthetic component, typical component include snug fitting baba socket, external elbow joint, figure X harness or shoulder saddle, and a cable control system with an elbow lock control and terminal device control once the elbow is locked. The system allow the user to flex the prosthetic elbow, lock it at a preferred angle, and operate the terminal device. What is wrist disarticulation? Wrist disarticulation is an amputation done through the wrist joint, removing the hand but keeping the entire leg of the radius and ulna. This level provides a long residual limb which is very helpful for leverage and control. Anatomy wrist disarticulation. The wrist includes the radius and 8 carpal bones arranged in 2 rows: scaphoid, luna, triquetral, pisiform, trapezium, trapezoid, capitate, and hematite. There are 2 main joints, radiocarpal joint and midcarpal joint. The wrist allows flexion and extension, radial deviation, ulnar deviation, and circumflexion. Rotation does not happen at the wrist itself, but forearm supination and pronation make up for it, and the hand moves together with the radius. Wrist disarticulation amputation consideration. This amputation is often chosen when a partial hand amputation will not leave a non-functional digit. Important considerations include 1. The stem is long, which is an advantage. 2. The distal radius and ulna flare outward, causing a bubble shape. 3. The styloid must be handled carefully. 4. Radial styloid should not be shortened, but trimming may be done to improve socket comfort. Myodosis can improve muscle stability and control. Socket design. Common socket design include superstellate socket with a panel opening, superstellate socket with a patch fit liner. Because the line is long, the trim line can be lower than its transradial prosthesis, but the socket must accommodate the flare at the styloid. Flare at the styloid to ensure comfort and suspension. Casting technique. Casting is similar to a transradial patch fit cast, but with extra focus and capturing the styloid shape accurately. A cutoff tube is often used to help remove the cast easily due to the bulbous distal end. Prosthesis option. There are three main prosthesis choices. 1. Cosmetic prosthesis. Lightweight, natural appearance but only passive function. 2. Cable activated prosthesis. Uses a harness and control cable, low weight and no battery required, making it useful for daily tasks. 3. Myoelectric prosthesis. Provide more natural function control but require strong muscle signal, heavier and needs more maintenance. The best choice depends on the patient needs, lifestyle, and muscle signal quality. And that is the detailed explanation of both elbow disarticulation and wrist disarticulation. Each level has unique characteristics, advantages, and challenges. By understanding the anatomy and prosthetic consideration, we can design and fit an prosthesis that give the patient optimal comfort, suspension, and functional. Transhumeral amputation level. Transhumeral or above elbow amputation occurs between the shoulder joint and the elbow joint. The level of the stump greatly affects what type of socket design can be used. If the stump is the distal third of the humerus, the user generally has better control similar to elbow disarticulation, although suspension and rotational can be more challenging. But if the stump is in the proximal third, it becomes more difficult because the bone lever is shorter and there is less stable surface for suspension. This requires more careful socket design to achieve comfort and functional control. Before designing a socket, we always need to consider one, rotational stability, suspension, range of motion, streamline design, and how much space we must leave for the elbow mechanism. Suspension is a big problem in transhumeral prosthetic because the limb shape does not naturally help the socket stay on. This is different from transradial where the forearm shape helps create self-suspension. Common suspension methods include 1. Harness suspension, usually figure 8 or shoulder saddle. 2. Suction suspension using a close-fitting socket. 3. Silicone liner with suction or locking system. However, using suction requires a very accurate fit, which can be challenging if their user's stump volume changes. Below acroneum socket design or open shoulder. This design does not extend over the shoulder. It leaves the shoulder more open and allows for a more natural feeling or movement. There are two main variations. One is the traditional below acroneum socket, the utah dynamic socket, which has aggressive contour to improve rotational control. The advantages of this design include 1. Greater freedom of shoulder movement. 2. More comfortable because it does not rub on body prominence. Allow better abduction range, but the disadvantages are 1. Less surface area for suspension. 2. Reduced stability. 3. less self-suspension ability. 4. Heavier dependence or harness or suction system because suspension is more challenging. Suction suspension or auxiliary strap are often needed. Process. The casting process began with applying stockinette, marking key anatomical landmarks such as 1. The acromion, 2. Clavicula, 3. Spine of the scapula, 4. Sensitive area, and 5. Stump and terminal reference. Negative cast checking. During negative cast fitting, we check one reinforced weak area, trim to the marked trimline, apply a new sock of the patient, donning the cast using powder, check comfort and position, test range of motion, and adjust trimline as needed. After that, we proceed to cast rectification where we check reduce excess volume, build up at acromion and stump, and lower the axial trimline slightly, shape the socket for comfort and function. Okay, now we're talking about the casting method and measurement. Casting is a very important step because it determines the shape of the final socket. Accurate casting leads to better comfort, suspension, and function. Step measurement is before casting. We take one belt length from acromion to stump and axilla to stump and acromion to axilla circumference at the proximal middle and distal stump level. We also take measurement from the sound side. From the sound side is axilla to lateral epicondyle, acromion to lateral epicondyle to styloid process and thumb tip. These measurements help us determine appropriate prosthetic length and component selection. If the patient is bilateral, we use formula for upper arm length, and this is for forearm length. Importance of patient training. Even with a perfectly designed socket, the user will not achieve good function without proper training. Transhumeral control requires coordination movement of the shoulder, torso, and remaining limb muscle, especially when using a body power system. Training includes learning how to place the humerus in ideal position for elbow flexion, practicing locking and unlocking the elbow, controlling the terminal device in different elbow angles, learning movement pattern to avoid excessive strain. For myoelectric user, training focus on producing consistent EMG signal, switching between modes, controlling the elbow and hand independently. The training process takes time, patience, and repetition. A well-designed socket makes this learning process much easier because it gives stable suspension and predictable control. Okay guys, for follow-up and long-term adjustment, the follow-up appointments are essential for long-term success. The prosthetist need to observe how the socket functions in real life and make adjustments as needed. Common follow-up include smoothing pressure area, adjusting trimline for comfort, modif alignment, repairing worn-out padding, recasting the user if limb shape changes significant. Because upper limb amputated often rely on purchase movement and function. Even small adjustment can make a big difference in daily comfort and performance. And that completes the explanation of transhumeral socket design and casting method. We discussed stem level type of socket design, suspension option, detail measurement, and full casting process. Understanding the step is essential to create a comfortable and function prosthesis that match the user anatomy and needs. Thank you for watching, and I hope this video helped you understand transhumeral socket design much better.